which is totally displaced, and the B2, where it's totally displaced with a segmental fracture going at the same time. So probably, if you are talking about an older adolescent, maybe you should consider, as an hypothesis, to treat surgically this B1 and B2. The question, and this was already explained by some of you, there is some concern about shortening. So how much shortening should we accept? Because if you ended up with a very short clavicle, and actually there was a paper published last year on the JPO, where they were claiming a need for elongation of the clavicle after fracture using an external fixator. Yes, it came out on JPO last year. And actually, this maybe is a source of concern. So how much should you accept for fracture shortening on a clavicle? 10 millimeters? Yes. Maybe, you know, I'll keep this between the age of 12 to 17, because until the age of 12, I think there is no doubt you're going to treat these patients non-operatively. Let's keep this for the adolescents and see what should we accept. We look about the classification, and now we're looking a little bit about the shortening. How much would you accept to have a shoulder that's going to be shortened compared to the other one? 2 centimeters? There is no evidence on this. There's no evidence. But so it's a number that we feel that we'll be a little bit comfortable on that, because you don't expect the clavicle to grow on the remaining time to compensate for that. But there is no evidence what is the importance, except for the cosmetic appearance, what is the importance of having a shorter shoulder? Because is this going to affect your sports activities? There is no evidence on this. So unfortunately, I think we have to stay and discuss again individual with the parents and how we're going to do it. So this is a very interesting study that was a questionnaire sent to the members of the Pediatric Orthopedic Society of North America. And you can see that here is between the 12 and 15, and they divided the 16 to the 19 is the two lower ones. And it changed, you can see how it changed a little bit the difference, because if you keep the classification of Edinburgh, you see that for A1 and A2, most of these patients are treated non-operatively. But the attitude changed a little bit, and that's where maybe you have to start thinking about an adult. But again, this is not evidence. This is a questionnaire sent to the expert's opinion. Can give you some support on how you should practice, but does not give you a guideline how you should do it. And you have to emphasize this. But there is no doubt when you talk about the 2As and 2Bs, and most of the 2Bs, especially on the age group between 16 to 19, probably you're going to end up by being more surgically approached than non-operatively. So what would be the indications for surgery? Definitely all agree on open fractures, neurovascular compromise, multiple trauma, maybe the type 2A and B after the age of 15. You should consider individual each of the patients, and I think this will help you in terms of making you a decision. So as a summary, fractures of the clavicle are a common fracture, 14.5 out of 10,000 children. It's the 5th most common fracture on the UK. There is a potential remodeling for young children, and that's why we treat 100% of them non-operatively. Failure to define the age group for surgical intervention. This should be discussed individually with the parents and in an approach what kind of activity the child is doing. Because if you have a very sporty athlete on the age of 15, maybe you should consider to treating these patients surgically. We need control for randomized studies, as every paper will say at the end. And again, each child, adolescent should be approached individually to avoid mistakes. So this is what I wanted to bring you about the fracture of the clavicle. It's a simple fracture, but still raising a little bit of questions nowadays. So I'm open for your questions, if you have any. Okay, if not, because it's an easy one, we'll go to the second one.
I have one question.
Please do.
You talk about the indication of fixation in a multiple fracture. What does that
In the polytrauma?
Polytrauma.
Yeah. I think, I'm very aggressive. We did not focus here the polytrauma child or adolescent, but maybe it should be one topic we should have addressed. I'm very aggressive in approaching a polytrauma patient. Maybe you have some experience treating the polytrauma children, but in my hospital where I used before moving to the children's hospital, I was working in a major trauma center in Lisbon, that was the Medical School of Lisbon, where we ended up by treating all these polytrauma children. And we were very aggressive in terms of treating these patients like adults. You really need to stabilize them and give them the right approach, because sometimes you need to move them to the X-ray department. You need to take care of the wounds. A lot of them have abdominal trauma, head trauma. They need to really have their fracture stabilized. So usually, for example, for the humeral fracture, that's a fracture that is benign, and you're going to see the next one. For example, I used to stabilize them with plates and screws. So to make sure that they have a really stable, especially if there is a neurological patient, because they get some convulsions and can get very stiff. I have seen the nails in a femur bending 90 degrees with a femur fracture on a child in a coma. So this is a kind of thing, it's not evidence, but it's a kind of thing that stays on your background and makes you feel like treating the polytrauma child as a real adult and giving them a stable fixation. You want to make a question?
Two questions here. One is, how much shortening would you personally accept?
For the clavicle?
Second is your comments on the type of fixation if you decide to do.
Mm-hmm.
Would you prefer a plate and screws, or would you use a clavicular nail, or what do you do? What's the current status of?
Okay, in terms of shortening, I would accept around 2 centimeters. I will discuss this with the parents, but I would say, okay, we'll accept a little bit of shortening on that, but I have seen that most of them, they do well without any problem. But this is my own evidence, if you can call it this way. In terms of the fixation, nowadays they have a paper talking about doing an elastic nail. Being a pediatric orthopedic surgeon, I'm very happy with the elastic nails, I have to say. No experience on the clavicle, because usually I don't operate on them. But the rare cases where I did with the plates and screws, in the old fashion, I would say. But I think that it makes sense if you have a simple fracture to approach it with an acetylene nail on the clavicle, because it will be easy procedure, I feel, and not so much scar. The only thing is that you can get an infection, because it's going to be the nail will be sticking out a little bit. You can have an infection down there, but if you talk to the parents about it, it's going to bother for 3 or 4 months, and then you take it out.
In the recent series of nail fixation, they found significant amount of shortening, 2.5 centimeter shortening they measured, in spite of the nail fixation.
Yeah, if you have an oblique fracture, probably that's not going to help you a lot. So I think you really have to look at the anatomy of the fracture. If you have a segmental fracture, it makes it nice to have just the nail, and you keep the periost and the sleeve, but you're going to end up for sure with the shortening in the same way. So I don't think it makes too much sense. On the papers that I review, for example, for the segmental fractures, they just put a plate over, not touching the fragments, so leave the periosteal sleeve intact, and the only thing that they were concerned about was exactly the shortening, so giving the length, the appropriate length to the clavicle.
There are newer nets. There's a Rockwood screw.
Yeah.
Which sort of screws in. It's almost like the Accutrad device.
Or the Herbert screw with to avoid shortening. Yeah, I have to say that I have no experience on this, honestly. No, for sure you don't want to use Kirchner wires on this, because you can have a very difficult complication. It's the migration of the Kirchner wire to the mediastin. Then you are really in trouble. So stay away from using a Kirchner wire, definitely.
Then it can break. This wire can break by the weight of the
Yeah.
One question.
Yes?
In our country, we see so many cases of various types of malunions of joints present in adult age due to so many, suppose femur suckling, genobharam, genobhalgam. But in our 10 years in adult practice, we have not come across any case with presenting some complication due to clavicular malunion. So, means,
Exactly. I feel the same way. That's why we decided to brought here the clavicle, because nowadays you see it in the literature that people are trying to push in terms of indications for clavicle fractures. But I totally agree with you. I have a very hard time to indicate, even when you have a fragment sticking out. Sometimes what I tell to the parents is, okay, let's heal the fracture, and if it does not remodel, just go with a burr, simple incision, and just take out that little fragment that is sticking out under the skin after it heals. I think it's much easier than getting an onion or an infection or whatever. So I totally agree with you. I'm having a very hard time to accept indications for surgery. The funny thing is that on that study for the POSNA, the questionnaire for the POSNA people, if you compare the surgeons that have less than 5 years of practice with the surgeons that have more than 5 years of practice, in terms of indication for surgery, it was much higher in the group that was practicing less than 5 years. So the older you are, the more conservative you are. And
True for everything.
no, it's not true for everything. Yeah?
Just got a call from the guy who's leaving, so can I please request you to?
Yeah, no
Please,
problem,
I'm
no
so
problem.
sorry.
No. Don't be sorry. Let me get out of here.
I'm, interrupting here with my talks because I need to leave,
No
so
problem.
please bear with me. Thank you very much. I'll be talking about supracondylar fractures, which I'm sure everybody is coming across. We are talking about a 5-year-old, and I was told to talk about type 2 fracture. Frankly, I have my own views about type 2 fractures, and I just want to share them with you. We had a 5-year-old with a trauma 4 hours back, fall on an outstretched hand, pain and swelling around the elbow region, no history of any bleeding or any other associated injury. And on clinical examination, there was a frightened, uncooperative child with a hyper-anxious family, as always. A splint put out at the primary health center with elbow at 90 degrees, but the radial pulse after removing the splint and everything was fortunately palpable. Neurologically intact, moving all fingers and thumb, generalized swelling around the elbow. So this was the X-ray. This was the X-ray. My resident called me up and he said that, I asked him what is this fracture? So he tells me that, I think it's a type 2 fracture. I don't think there is any problem. So I promptly came in and I told him, let me come and see the X-ray. And I said, the lateral view, this is not a true lateral view. Let's get a true lateral view. So we got a true lateral view, and surely enough, you see that spike of the proximal fragment, which suggests that there is some rotation and impaction. So one needs to be extremely aware of the fact that you have to be have a very low index of suspicion for a displaced supracondylar than thinking about it's non-displaced and can be treated in some other way. Now, in this case, we went ahead, and sure enough, when we gave a traction, there was a lot of instability in that fragment, suggesting that it was actually a type 3 fracture, and we ultimately fixed it. And sure enough, the pins were removed after 3 weeks. That's the standard protocol that we follow, and it followed by active assisted exercises, and the child did well. Now, I just want to share with you type 2 versus type 3. Now, are we sure whether it's type 2 always? How many of these typical type 2s do we actually see? Now, this is a typical type 2 probably. We are just seeing the lateral view. And often difficult to be sure regarding stability of the fracture fragments during reduction. And these definitely are not type 2 because there is a coronal displacement, there is rotation. And to reiterate, 6-year-old fall on outstretched hand, swelling, again the similar kind of a situation, no associated injury. Usually you see the anterior humeral line, it usually cuts through somewhere around the middle of the capitulum, but if it starts going anterior, then you know that there is a posterior angulation, it's an extensor type. And then, like, some people might talk about, looking at this and saying that it is type 2. Obviously it is not, because when we took this kid in and this was totally unstable, and it actually, this particular case, it took a long time to get the reduction, and so unstable, difficult to pin. But ultimately, we just accepted these 2 lateral pins, and fortunately the child did well without any displacement in the future. But we prefer cross pins generally. So the type 2 concerns is the correct diagnosis and stability after close reduction. Are we sure it is type 2? That's the question. Now, any doubts regarding stability or any vascular concern, treat it as type 3. So, now just coming to the supracondylar fractures in general, extensor type is around 95%, but flexion types, you have to be aware of them. They are about 5%. And the mechanism of injury is extension type, fall out, extended outstretched hand, hyperextension, olecranon into the fossa, bending forces at the supracondylar region, which is vulnerable in that age group. And standard classification is a Gartland, type 1, type 2, type 3. And you have the mechanism of injury, where in type 2, partial break in the distal humerus with leaving some posterior or anterior cortex intact, and a complete displacement in type 3. Now you have this type 1, the Gartland extension force, anterior cortex break, fat pad sign, no displacement, and then that goes on to, it all depends upon how much of force is being extended. So the type 2 and more extension force, we're talking about the extension injury here, more some posterior cortex intrinsic stability plus minus again, and then type 3 when you have this total complete displacement. So you, for something to be a type 2, you need that force to be exactly stopping at this particular point in order to get this as type 2. Now, similarly, when you see the X-ray, you have an extension force, same thing on the X-ray that you are seeing right now. Okay, now this is type 2 and this is type 3 as we just. Now, classification is entirely dependent on the pre-reduction radiograph, which in turn is dependent on, you have a hyper child who is like moving like crazy, and you need a child's cooperation. Invariably, in 95% of cases, it's not there. And the X-ray technique, the quality of films, so you need to be absolutely sure what you're looking at. And pre-op assessment, you have to do a complete neurological, neurovascular exam, soft tissue swelling, ecchymosis, puckering, whether there is puckering or not, concomitant ipsilateral forearm fractures, any other fracture which you are missing out, or is there any increased risk of compartmental syndrome, especially in cases which come to you late with a splint which has been put about in 90 or maybe more than 90. Now, as far as we are concerned, closed reduction and pinning in all closed, acute, displaced, but reducible type 2 and type 3 fractures. And when there is a comminution of the medial column, then that particular fracture, even though it might seem very innocuous, it has a highest tendency of going into coronal displacement of varus, so you need to fix that. And medial, you need to look at the medial and lateral columns. If there's a loss of medial column, we just discussed that. Comminution, this kind of a comminution, you want to take it more seriously. And visualization per op, you generally end up in a per op, we'll come to that. Per op, you end up with a flexed forearm because you want to keep that fragment stable, and you end up seeing this kind of a view, which you should know how to interpret per-operatively. And the role of pronation is very interesting. I mean, in a posteromedial displaced fractures, medial periosteum is usually intact, placing the medial periosteum in tension and closing the lateral side. So in posteromedial fractures, it makes more sense to do a pronation, hyperpronation that we do, even for that matter, before a closed reduction and fixation. But a medial periosteum is torn in the posterior lateral displaced fracture, and pronation is counterproductive. So you need to keep that in mind also. Just illustrating, this closes the hinge and the elbow is flexed and correcting the varus. Now, advantages of a medial lateral pin: more stable construct for rotational stability, must engage both lateral and medial columns. So when you are introducing the pin, you need to make sure that you first face a resistance, then there is a loss of resistance, and again you face the resistance. So sometimes you don't have to keep that C-arm on for a long time. You can always, have a feel of what you're doing. And medial side, yes, one of the ways of actually reducing the chances of injury to the ulnar nerve is you extend the forearm after putting the lateral pin first, extend the forearm to about maybe 80 degrees, and then probably give a small 1 centimeter incision over the medial epicondyle, see where you are inserting the pin, and then put the pin. So chances are very less. Even then you have a few chances, but invariably, fortunately, Even if you have a neuropraxia and an ulnar nerve palsy, it usually recovers. Most of the papers say that. And even I have had a couple of cases which ultimately recovered. And SCAGs in JPJS in 2004 clearly mentioned, it's been reiterated in lots of other papers, that the most stable construct is a crossed pin or a 3-pin construct. So our pinning technique is generally cross pins, and we do not want to hyperflex more than 120 degrees and hyperpronate, because that increases the chances of any compartmental syndrome. So the internal fixation, that's one of the roles of internal fixation, that you want to avoid that, because during my residency I clearly remember that we used to treat most of these type 3s by close reduction and hyper positions. So but that needs to be avoided. Now there are studies by Mapes and Henricus in pediatric or JPO18. It was a prospective study, and evaluation it evaluated the effect of various elbow positions on blood flow. And then it was concluded that the vascular safety is enhanced by elbow extension and forearm supination. Similarly, there was a Battaglia et al. JPO 22 evaluated forearm compartmental pressures in 29 patients and concluded that more than 90-degree flexion of elbow increases the pressures closer to the fracture. So all these just reiterate what I just said. So thus internal fixation by K-wire fixation after close reduction gives one the flexibility with regard to elbow and forearm position, and avoiding extreme positions decreases the risk of compartmental syndrome. And reviewing literature by Wilkins, who gave his account of supracondylar fractures in JPO part B, he talked about percutaneous pin fixation for reduced fractures, the ideal treatment, and medial lateral or 3-pin construct being the most rigid fixation. Anterior interosseous nerve is probably the most common neurological injury associated. Pink pulseless hand, controversial management. Flexion type may be more, and displaced may require an open reduction. So flexion is something which you need to be aware of. So the thoughts: communicate clearly with the family, close reduction always under anesthesia and with per-op imaging, C-arm, warn regarding possible need for internal fixation even if it looks like type 2, have a low threshold for internal fixation. Risks for not pinning may be much more than the iatrogenic risks of pinning itself. If associated neurovascular complications or ipsilateral fracture is there, so internal fixation is essential, with or without any open reduction. And finally, compare with the normal side. Majority of displaced fractures, close reduction and internal fixation, it's pretty much safe. Pin fractures, the pin fractures with medial column comminution. Neurovascular status assessment, both pre and post-op, is extremely important. Look out for puckering or ecchymosis. You may postpone pinning to the next day, more than 8 hours in fractures without complications. And finally, feeling of bony contact and reduction is good. Sufficient bone should be engaged in proximal and distal fragments while pinning. Most stable construct cross pins or 3 lateral pins. First pin lateral and see medial epicondyle extend elbow to neutral or even extend it more before putting the medial pin. Pin should cross always proximal to the fracture. Leave wires bent about 1 to 2 centimeters off skin to prevent migration. Monitor radial pulse, manual or Doppler or perfusion throughout. Pronation useful in posteromedial fractures, like we just discussed. Except some translation or rotation, but not frontal or sagittal angular malalignment. Cast at 90 degrees or less, and no to hyperflexion and hyperpronation. Most post-traumatic and iatrogenic nerve palsies recover spontaneously without active intervention. Open reduction not indicated only for post-traumatic neuropraxias like radial nerve palsy with supracondylar fractures of humerus. Open reduction is indicated for an irreducible type 3 fracture which may be associated with any nerve injury. Focus on the nerve, but focus on the fracture, but observe the nerve. Thank you very much. Sorry.
Can I just raise 2 points?
Please.
There's lots of really, really good stuff in that. It's excellent. 2 things that are a bit controversial. So Skaggs' paper never said that, although Kay Wilkins did in this paper,
Yeah.
he didn't say that 3 lateral pins are equivalent to cross pin. It's actually that 2 divergent pins laterally is equivalent to cross pin. So as a result, they'll give only lateral entry pin. So we don't at all use medial pinning at all. So all our pinning laterally with 2. very occasionally you need 3. Those are completely unstable. And the sort of completely unstable ones like you have that run all over the place, that you will classify as a type 4.
Type what, sorry?
Type 4.
Okay.
Modified dominant type 4 with a different, entirely different bit of words. Multi-directionally unstable when you try and manipulate it. The second thing is that if you have a nerve injury that's happened after you've had it and put the pin in immediately, it's wrong to assume that is many of them get better because they've we've published extensively on that. They have nerve injury units that I've worked out that we've written all about it. They don't get better. In fact, you often have to do something. You certainly have to take the pin out. And if it's not getting better, you often have to explore the nerve. If it gets better, then you're very lucky. And that's because you
What is your, like some, if you do a pinning and you find ulnar nerve palsy, what would you do? I mean, how would you approach it? I mean,
so we would take it back
immediately.
immediately and take the wire out. If we couldn't get them back to place for one reason, we'd take the wire out and then observe.
That's a controversial thing, I think. What do you think, Dr. Jody?
I think if there's a nerve injury, it's detected post-operatively, then better take out the wire. Because the nerve may be trapped.
No, actually what happens is there is a kind of a fascia. You may not be actually going through the nerve.
No. So that was published by Russell.
You're right.
Which was that you don't have to be next to the cubital tunnel.
Right.
Next to it, and that causes fibrosis or it just kinks it. But even then, there's a kink, and that's not going to go to your wire. So you can't leave it, and you can't expectantly manage a nerve that's stopped working after you've integrated, because that means there's an iotropic injury to it. Something's happened to it. You need to know what that thing is. You need to see what's going on. So that's the only thing.
Okay, I mean that's an interesting point because every time we have a discussion on supracondylar, we have actually come. I mean, I'm not saying it's a right consensus, but we have ultimately finished the discussion by saying it's better to wait because lots of studies. I've yet to come across a study. Honestly speaking, maybe I've not done a extensive lit search. Okay, when is that? Can you give me the? Okay, I'll. Thank you very much. That's a very important point. There is a point which has been made that if there is a post-pinning neuropraxia, especially involving the ulnar nerve, and you are put on medial pin, then probably you need to be thinking about removing the pin immediately and wait for the nerve to recover. So that's one point which I'm not too convinced with about, to be honest, because I have had situations where the nerve has recovered. If there are no more questions, can I start the next talk about the fracture neck radius? Fracture neck radius is not as common as a supracondylar fracture, but we need to be talking about it because now here was a 9-year-old boy who fell on the ground a few hours back. It was an indirect injury to the right elbow region. The parents were very sure it was not a direct injury. Pain and swelling around the right elbow, unable to move the right upper limb due to pain. That was the basic complaint. On clinical examination, swelling just distal to the elbow. Neurovascular status of the upper limb otherwise fine. Slight flexion extension but no pronation supination due to pain. Bony tenderness over the proximal radial region, no evidence of any other associated injury. Now, this was the X-ray after the injury. Now, apart from what you see in the proximal radius, there doesn't seem to be any other injury. And if you actually measure this, this is definitely more than 60 degrees of angulation. So, what we did was I generally start with a kind of a Patterson maneuver in which we keep the forearm and give traction in full extension and giving a valgus kind of a thrust, we actually push the radial head and see without too much of traction, not being a little gentle in the whole thing. If that doesn't work, then we actually flex the forearm to about 90 degrees, which is more of an Israeli technique. We'll probably come to that. And then hyperpronate and then push the radial head, or rather then just apply pressure to the distal part so that it goes and locks itself, because the radial head is supposed to be already in a hyperpronated position. So, but in this particular instance, it got reduced by Peterson maneuver. And what we do is when we put the wire in, we can fine tune the proximal fragment to get the right kind of reduction. So that's what we did. And this kid in the check X-ray, we didn't put the pin through the humerus, which sometimes people do, which is not supposed to be done, and it's only to be condemned. We actually put it from the side, and we left it, and we removed this pin after 6 weeks. This actually I wanted to remove it after 3 to 4 weeks, but this kid came back after 6 weeks. But after 3 months, terminal 10 degrees of both pronation and supination was restricted. We didn't get the full range of motion. But then, when we talked to the family before the surgery, we definitely told them, because we have to be very clear, because with fracture neck radius, we always never seem to get a proper result, especially with so much of angulation. So I think then this patient was lost to follow-up. The child was back to school and everything was okay, except for the last few. So how much tilt is acceptable? That's important to understand. And what we have to understand, the message is, in less than 10 years, 30 to 45 degrees of tilt is acceptable. But in more than 10 years, it is 15 degrees only. So probably you may not, it's easier to understand. 10 is a nice figure to understand, so we keep 10 years. But then, on an individual basis, you can take a few decisions, but more or less this is what is the norm that needs to be followed. Now, how do we manage? Those within the acceptable limits is less than 30 degrees, and the ones who are more than 30 degrees, we try to get them to this particular thing for us to accept what we finally get, either by close reduction or by supplementing it with a kind of a pinning. And what are the reduction maneuvers? I have already talked about it. One with Peterson is with the forearm in full extension. Then you have a flexion and hyperpronation Israeli method. You can also use an S-mark bandage, or this is the Peterson method, which is just being elaborated. We just talked about it. The assistant gives a varus strain and traction, not any other strain. What if the close reduction fails? What if it fails? Then we can try putting a K-wire on the proximal fragment and try a guided closed reduction under image intensifier. Sometimes you can also put it in the fracture site and try to lift it, like, for example, this. So what you do basically is, this is what you do, and you get the reduction, and then you can pin it separately. And looks like a simple procedure, but you know there are lots of structures there which you need to be aware of. So you need to do it, keeping that in mind. The options of open reduction is best avoided. If you can avoid, well and good, but sometimes you probably need to do an open reduction in extremely displaced and tilted fractures, and then you need to be talking to the family about the prognosis, because even if you have a great reduction, you may land up with loss of pronation supination, which is what you need to be conveying. And humero-radial pinning is not advisable. Now, there is something called as intrafocal pinning, which you can try. You do this and you actually pin it in the same sitting. So that is also one way of doing it. In this particular case, this has been done, and sometimes you need to be, when you are pushing the pin in, you actually bend the pin proximally. So that sometimes works pretty well. Now, the Mitizos, I hope I'm pronouncing it properly. That's also a technique which I'm not very familiar with, but it's supposed to be a very effective technique. Introducing a single titanium nail of the right diameter from the distal radius towards the proximal, then probably trying a reduction maneuver and inserting, or sometimes you can use an elastic nail, sometimes you can actually use a K-wire with it slightly bent and try to engage it into the proximal fractured fragment and then twist it and get the reduction. So that's another way of doing it. You can also supplement it by a K-wire from outside. So what all these things, why we are basically conveying it, because we want to avoid an open reduction. So we try to avoid the open reduction, because once you open it, the chances of a good outcome is not very high. So what are the problems with radial head excision in children? Sometimes, it's just a thing. I mean, we're not even discussing that, but I just had a slide. So cubitus valgus, infra-radio ulnar joint subluxation, ulnar styloid impingement, no instability or cubitus valgus in patients 12 to 14 years with radial head excision. So here is a paper which says that if at all you have to wait somewhere around 14 years before you think about it. So the carry-home message is up to 30 degrees angulation in less than 10 years of age, and up to 15 degrees in more than 10 years of age is acceptable. If angulation is more, try all possible efforts at close reduction. And for malunited fractures with restricted movements, radial head excision only after age 12. So just a carry-home message. Any questions, please? Any comments?
Can you elaborate Peterson maneuver?
Okay. I can probably demonstrate on you if you can just come here. So you have somebody giving a traction. You have somebody giving a traction, your assistant, and you keep a thumb here, and there is a pushing it not you first the traction for a little while, then a varus stress. You have a hand here. So the guy is giving a traction and he is taking the forearm here, you are holding it, giving a three-pointer here and trying to push this in. Or if that doesn't happen, then you actually hyperpronate this and push this, you hyperpronate this and gentle, you have to be very gentle and try to press this. Sometimes because the head is already hyperpronated, you are just taking the proximal fragment and trying to align it there. Sometimes you can get that. And then it can get engaged, and then when you bring it back to mid-prone, sometimes it can carry the radial head back. So that kind of a thing can happen. So these two maneuvers that we generally, and it has to be a little gentle. You want to add anything in this?
No. If the case comes into police cold with more than 30 degree or 40 degree.
That's a good question. I personally would wait. Once it has started uniting, because I don't think doing anything, because close reduction is not going to work. The only thing that is going to work is an open reduction. So in that kind of a situation, the only thing we can probably do is wait and see how much of a problem faces, and then decide whether anything done after the fracture is fully united, whether that can help. What do you have to say? I really don't have an answer to that.
The younger the child, I guess you wait for remodeling to happen. The problem comes in 12 years and beyond. Maybe a role for breaking the callus and trying to.
Okay.
Any problem with the translation? Because sometimes we have been talking about the tilt, angulation, but also with during pronation, supination, the X of the radial head is different from the radius itself, and the head should have some impingement. How much should you have set in terms of translation?
I think I would accept at least 40 degrees of translation. I mean, if it is in contact.
Okay, 40%.
40%, yeah. 40%. And it also depends upon, I think the age groups remains the same. That would be for less than 10, I would probably accept about 40, but more than 10, at least 60 degrees of contact needs to be there. I think that's how I would look at it. I mean, because the chances of, again, the same thing happening, this kind of translation affecting the pronation supination is always there. But I think all the studies talk about the radial tilt. Actually, the translation is something that people overlook and oversee. Actually, they say that things get better pretty fine. It's always the tilt.
So you are planning for a fully displaced fracture neck radius, and you are trying to manipulate, and it goes further towards the ulnar side. What next?
Towards the, it actually overshoots,
overshoots
and goes to the ulnar side.
Yeah.
A bit difficult to explain that because,
That happened.
okay.
And then I have to do an open reduction, and then I have to get it.
Do you have any kind of a...
Like you have to deliver it out.
I haven't really seen that.
Deliver
I've
it
seen more
openly.
that it flips 180 degrees. It's basically the other way.
Open reduction.
And then you need to-
Yeah, did it translate totally or did it flip?
No, it flipped and towards the ulnar side. It rotated and it goes towards the ulnar side.
Over reduced.
Over reduced.
Over-reduced. What were you doing? You were doing a Peterson maneuver?
Yeah.
Okay. Yeah, please go ahead.
I think that most of these cases happen when you have an elbow dislocation and you don't recognize it.
Yes, yes.
So it has a lot of soft tissue injury connected with this. And actually that's what you call sometimes a translocation on the radial to the ulnar, and sometimes only the radial hand translocate to the ulnar side. So I think, you know, you have to be very careful how you handle these patients because they have a really bad prognosis in general. So, I don't know, will you talk to an elbow dislocation?
No, I don't think so.
Next time, too bad. Because actually, I develop a classification for elbow dislocation when I have 3 types of you know, type 1 where you just have a soft tissue injury, type 2 when you have a medial compartment lesion like the epicondyle, the medial epicondyle, and the type 3 when you have plus the lateral side.
Capital.
Yes, and then it means that you have a severe injury on the lateral collateral ligament, so you have a severe instability. And if you ended up with this problem, I think it's you really have to understand what's going on because sometimes you need to do some soft tissue repair associated to this. So it's a very rare lesion, but with a terrible prognosis. And in my own experience, it goes now, an article is going to be published now, soon hopefully. I have 78 cases, and it's 68% that have a type 3 with a terrible, bad prognosis in terms of range of motion.
Thank you.
Then you need to open reduction and cable fixation.
Well, that's the problem. If you ended up by opening some of this, especially if you have a radial hand fracture, you have a very high chance of having calcifications around, heterotopic calcifications.
Yes.
And you really are in big trouble.
Both sides. Both sides.
Thank you very much. Thank you.
I'll put it in a minute. It's really nice to meet you. See you soon. Yeah, see you soon. I'm just going to put this up first. This is the paper on what happens to ulnar nerve injuries. It's in the JBJS, and it's from 2006. And the vast majority of tertiary referrals to a nerve specialist center are from ulnar nerves that have been skewered or come close to being skewered by the medial pinning. But I can go into that detail. And there's a meta-analysis that Charles Mellman, C.T. Mellman's done from Cincinnati on it. But anyway, we'll come back to that. Happy to discuss that. So we'll talk a little bit more about supracondylar fractures, but when we have soft tissue injury and the pink pulseless hand, and what to do, because that's a controversial area which Ramani alluded to earlier. So here's a 4-year-old boy with a right elbow injury, left elbow injury. So if you see that and you know that's a severe Gartland fracture, so it's a 3 or a 4, you're expecting bad things, and you have to document the neurovascular status of the limb. And you go to, what noise is that? Is that me making that noise? It doesn't matter. It's like I'm taking a photo. So when you examine the boy, you see this in the elbow. If you see that, in your experience or your opinion, what do you think is the most likely finding? If you think it's an arterial injury, put your hand up. If you think it's a nerve injury, put your hand up. If you think it's a difficult reduction, put your hand up. Let's actually see a difficult reduction because that's buttonholing of the brachialis. So the proximal fragment buttonholes through brachialis, the muscle, and then you get this hematoma, blood underneath the skin, and the distal fragments of extended at the back. And so there's brachialis penetration, and there are good studies. This is from Salt Lake City, Utah, Chris Peters. And they showed that in 92 of 152 fractures that they saw, which were displaced, Agartum type 3, so brachial muscle interposition was diagnosed by physical examination or intraoperative findings in 18 of the 20 initially irreducible fractures. So the vast majority that you can't reduce, muscles got in the way. But interestingly, if the muscle's in the way, there's still a high chance that there's a nerve or arterial injury. So don't exclude the nerve arterial injury, but the first problem is going to be the difficult reduction. If you've got a displaced posterolateral supracondylar fracture and you've got a neurovascular deficit, be careful. If something's not right with the hand, don't manipulate it very roughly. You might need to go straight to an open reduction because that vessel and the nerves are probably kinked over the fragment, and you manipulating it roughly can make it a lot worse. So the usual scenario is you see that, and then you feel the pulse, and you can't feel a pulse. So this is a normal Gutland type 3 fracture. You can't feel a pulse, but the hand is pink and it's warm. What would you do next? Would you get any investigations? Probably. Would you get a Doppler ultrasound scan? Yeah. What about an angiogram? Some people will do an angiogram. Okay. So we go back to what evidence we have in the literature. So Doppler ultrasound scan is a useful thing to do, to see if there is any flow. And there are lots of studies that have looked at using it as a part of your management tool or investigation tool before you decide what to do. So in this from CHOP again, Children's Philadelphia, out of all their grade 3 supracondylars over 6 odd years, 128 cases, 17 had absent or diminished pulses, detected with Doppler but not palpable. 14 of these 17 recovered the pulse after reduction, and the remaining 3 had persistent absence, and those were explored. So it does help you think about which ones you're going to go in and explore. Angiography, on the other hand, is a no-no. So the literature over and over again will tell you that there's no point in angiography for many reasons. Number one, you know where angiograms are normally done to find out the level of the lesion, where along the vascular tree it's blocked. You know where it's blocked at the level of the fracture. So it doesn't tell you that any more than knowing it already from the injury. And secondly, it doesn't really change your management, because whatever happens, you've got to go in and open that up anyway, right? So if you've got a completely blocked off vessel, then your hand's going to be pink. There might be some collateral circulation. If there's enough of a collateral circulation, then you may not necessarily have to explore it because the hand is perfused. So it's not really about what's happening at the level of the vessel. It's about what's happening around in terms of perfusion, and that's the more important message. So you take this child to theatre and you reduce and fix the fracture, and the hand is still warm and pink, but there's no pulse. So what do you do next? Would you watch and wait? Watch and wait? Okay, good. I'm happy you know. How many of you would explore the brachial artery at that point? Okay. But the fracture's been reduced now, look. That's what the fracture looks like now. It's back, it's reduced, and the hand is pink and warm, but there's no pulse. So certainly there's no question that if you do that and it goes white, then you've obviously trapped the artery. But then you have to go, right? But it's still perfused. So there's so the Cincinnati people, so Alvin Crawford, Charles Melbourne, they've surveyed Posner to see what people would do versus what the evidence says. So Posner, Pediatric Orthopedic Society in North America, they looked at the literature and found 331 cases of pulseless supracondylar fractures in the entire literature, of which 157 remained pulseless after closed reduction and stabilization. Of the ones that continue to be pulseless despite adequate reduction, 82% were found to have a brachial artery injury. Posner members thought this number would be a lot less. They thought it would be 28%. So we think a lot less would be injured, but actually a lot more are injured if you go in and explore it. So total of 98 perfused supracondylar fractures identified. Of these pulseless perfused fractures, 70% of the document brachial artery injury, and Posner members speculated this would be 17%. They thought it would be a lot lower. So there is probably more injury than we think, but the question is, does it matter? Does it matter if the hand is pink and perfused, but the pulse isn't there. And all the literature actually points to the fact that it doesn't matter, because the pulseless pink hand after reduction, even though there's no pulse, tends to do well. So this is from Dave Skaggs again in LA. It's where I did one of my fellowships. Largest series of children with pulseless supracondylar fractures. So at 33 from a single center. There were two distinct populations. So in patients presenting with a well-perfused hand, fracture reduction alone was sufficient treatment in all cases, as long as the hand was well-perfused, even though it's pulseless. And none developed compartment syndrome. Nearly half of these patients still had an absent palpable pulse, but well-perfused hand after close reduction, yet did well clinically. Those presenting with a poorly perfused hand, so a whitish hand, all went on to have vascular repair, or ended up getting problems like compartment syndrome. And if you look at them further long term, so this is this month's JBJS American, right? And this is from Stephen Frick in North Carolina. So they followed these pulseless pink hands after they'd been fixed, no pulse, but pink, for an average of 20 months follow-up, so much further down the line. Children with a perfused pulseless supracondylar fractures that had been treated with closed reduction, pinning, and observation demonstrated a palpable pulse, normal growth of the arm, and good, excellent functional outcomes. Although 5 still had an occluded brachial artery, it didn't matter. They had good outcomes, so it doesn't matter. And if you look at there's a systematic review of all the vascular complications. This was done by someone in Cambridge. A child with a pink pulseless hand post-fracture reduction can be managed expectantly, unless additional signs of vascular compromise develop, in which case exploration is advisable. So leave it alone. As long as it's well perfused, leave it alone. So the algorithm really is with a warm, perfused, but pulseless hand, you do an emergency operation. It's not absolutely, you don't have to do it right away, but emergent, so quick as you can. Reduce and wire it, then get the arm out straight and watch it. And you can have a look at it and see what happens. And as long as it stays warm, return to the ward, but then observe them closely. But if it's cold, or you've made the pulse disappear, you need to explore it and look at the artery. And often think about doing a fasciotomy to stop a secondary compartment syndrome. If you first see the child in the emergency department and you can't feel a pulse and the hand is white, what would you do next? Who would do urgent surgery and explore it? I hope most people would. I hope most people wouldn't just extend the elbow and wait, because extending the elbow is not going to make much of a difference. It's actually, and the child is in pain with a broken bone. So a wide pulseless hand, is vascular exploration necessary? Again, this month's JBJS, so there's been a lot published very, very recently. American JBJS, this is from Christine Ho and colleagues in Pittsburgh. So nearly 10% of patients presented with type 2 supracondylar humeral fracture and no palpable radial pulse underwent vascular repair. So for them, the important thing was the clinical finding that the limb was well perfused. If the limb wasn't well perfused, whether that's on Doppler or clinically, then they're much more likely to explore it. And if you've got a white hand, you have to explore it. If you're not happy to explore it, you need to have a vascular surgeon and colleague and friend with you who does it. And you need to think about how you're going to do it, which we'll talk about in a second. So cold, immediate operation, reduce wire, extend the arm, and reevaluate. And if it hasn't got better, explore fasciotomy, and then observe again afterward. So if you're going to do an open reduction, which way would you go in? Medially? Anyone? Laterally? Laterally, okay. Posteriorly? No. Anteriorly? Posteriorly, anteriorly. What did you say? Posterolaterally? Posterolaterally, okay. I didn't put all the other 25 combinations. Supero-inferiorly? No. So actually, it doesn't matter, but you've got to try and get to where the money is, right? And the money is at the front. So you could go anteriorly, you could go anteromedially, you could go anterolaterally. It doesn't really matter. And the literature doesn't point one way or the other. I'll tell you that I go in anteriorly, and I tend to do it. I was taught to do this by a vascular surgeon, is make a crease in the, use the elbow crease and just go across it. And then all you have is a bit of fat, a bit of muscle, and all the vessels and nerves are there in front of you and the fragments there. You just do it slowly and carefully. Coming around from the outside or the inside, there's a bit more dissection to get around, but there's no reason that that's not any good either. It doesn't, I don't think it matters as long as you get to the money.
Any investigation prior to restoration?
No. So the white hand, if it's white and it's a supracondylar, the lesion has to be there. But which investigation would help you? Would change your decision or your approach? It's the injury is going to be at the fracture. So you have to get to the fracture and you have to look at the vessel there. Just talking about open reduction as a whole, so not just for vascular approaches. So this is from Turkey. The anterior incision with open reduction is needed offers a smaller scar and easy access. So the Turkish are big proponents of an anterior straight across approach. If you look at all the approaches, and this is a systematic review from JCO in 2010, that the combined anteromedial approach is probably the best method. And this is not for vascular, this is just generally for open approaches. So you're coming in anteromedially. But you know, all these papers about open approaches, they're not too many numbers, it's not huge numbers at all, so it's based on limited evidence. Certainly the posterior approach is not a very good approach because you're a long way away and you get lots of scarring and stiffness related to the triceps exposure. We already discussed it, I mean Ramani talked about this already. That's the forearm position. After you do all this, what position should you put the forearm in? The whole point of pinning an elbow fracture is so that you can put the arm in any position afterwards. You don't need to worry about stability. So it's not good if you pin it and then put it at 110 degrees to try and hold it. There's no need to. The wires are holding it, so put it out into extension. It doesn't matter. You don't even have to put a cast on afterwards. You can put just a padded sponge type bandage. Lots of people use that so that it's comfortable. So this is Mapes and Henriquez's classic paper saying that if you go above 90 degrees, you start kinking the anterior vessel. So you try and keep it out less than 90 degrees. And in supination also is a better position than pronation. So in summary, watch out for buttonholing the brachialis. The most important thing about the brachialis into buttonholing is that it makes your reduction difficult, but it is associated with nerve injuries and excuse me, vascular injuries. The pink pulseless hand, more often than not, you're just going to reduce it and fix it and then let it remain pink and perfused but pulseless, and the pulses often come back and the collaterals build up. The white pulseless hand, explore the artery, use whichever approach you want. I tend to use an anterior approach, and the vascular supply does recover in the pink pulseless hand. I'll stop there, thank you. Any questions or any points? Yes.
How long do we wait after like you said, we watched the immediate post-op period before exploring. If the limb is cold, then we explore after close reduction. So how long is the waiting time? I mean,
If the limb,
like we did a close reduction,
yeah,
and the limb is still cold, how long do we wait?
you do it immediately. I mean, say if it's not coming back.
How long do we observe before going in?
As in you don't wake the patient up. You sit there and watch it. And if it's still white, you open up there. So you don't wake the patient up, take them to the ward, and then keep looking at that white hand for another 2-3 hours thinking I should have done something. You do it right there.
Should be inside the wall.
Yeah, so once you do this, you wait a few minutes afterwards while they're asleep. Don't take the patient out. Keep the child there. Yeah. Okay. Oh.
Usually it's the time for the vascular surgeon to come in. And
Yeah.
you started to have some pink hand.
Yeah. By the time you're getting, exactly, you get worried, you call the vascular surgeon, and then you say, I'm going to start doing it, come. Then he comes and it's pink, and you say, well, thanks for coming.
Sorry.
Yeah. But better safe than sorry. Yeah. Okay, thank you.
That's okay, it's okay. So now we're going to the complications of the supracondylar fractures. So this is an 8-year-old boy that had a supracondylar type 3, treated non-operatively. And of course, he ended up with this situation, although he has a full range of motion, no vascular neurologic complications, and this is the clinical appearance. And when you look at the X-ray, this is what you have. So I think we all agree in terms of what kind of deformity you have here. It's a very common thing, unfortunately. My question, and this is because I was trained, there's looking at this just like a cosmetic deformity. And I still remember, you always have these clinical cases that give you some experience. I remember when I started practicing, one of my first private patients actually came up with a supracondylar fracture, type 2. I knew they were going to end up in a varus position, and I told the mom, okay, to fix this, you need to go into the OR and the general anesthesia. You need to be reduced and then fixed or put a plaster, but it's the only way of getting correct. And the mom asked me, what about if I don't want her to go to under general anesthesia? Well, it stays with the varus deformity of the elbow, but the function will be perfect. So how do you consider this? Is it a cosmetic deformity or is it a functional deformity? You all think it's functional? Because these patients tend to extend and flex normally. It's just when they extend, they feel that they are crooked, and the parents get very unhappy with it. And the funny thing is, when I got this this lady that came 20 years later to my office with her child, I asked, let me see your elbow. How is it doing? Well, not doing so well, but okay, I'm managing. She's an architect, doing very well without any problems at all. But is this the case with every single patient? That's what we have to ask for. Because this is a big deformity, and actually, when you're looking at this deformity here, it's a big deformity on the EP plane, and you can see that with the time,